Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar session. Today's topic is non-communicable diseases and mental health, prevention, screening, and management among PLHIV. And the speaker is Dr. Sachin Kataria. Dr. Sachin Kataria is currently working as a senior medical officer with the ART Center at Nayak Hospital, New Delhi. He has done his postgraduate advanced course in cardiac management from the University of Boston. He has also completed the certificate course in clinical management of HIV from the University of Washington. We welcome you, sir, for today's session and request you to start the session.
Thank you, Shweta. Next, please. Today's session objective would be an introduction to the non-communicable diseases, hypertension screening, diagnosis, and initial management in adult PLHIV cases, diabetes mellitus screening, diagnosis, and initial management for adult PLHIV, cardiovascular disease risk factors, screening, assessment, and initial management for adult PLHIV. We will also be covering some part on mental health among PLHIV and common cancers among PLHIV. Next, please. So we will start with non-communicable diseases among PLHIV. Next, please. Just a brief introduction that since the increased ART coverage, PLHIV are virally suppressed and are living longer and require a comprehensive health and well-being approach. Over the last 26 years, the country's disease patterns have shifted. The mortality due to NCDs or the non-communicable diseases are increasing, contributing to overall disease burden. And NCD caused by a combination of genetic, physiological, lifestyle, and environmental factors. Next. So the common non-communicable diseases of the system include the cardiovascular system, which includes hypertension, ischemic heart diseases, stroke, rheumatic heart disease. Respiratory includes asthma, chronic obstructive pulmonary disease or the COPD, occupational lung diseases, cystic fibrosis, pulmonary hypertension. Endocrine includes the diabetes type 1, type 2, paradiabetes, and gestational diabetes. Renal involvement includes the chronic renal disease. Next, please. Central nervous system or the psychiatric part includes the depression, anxiety, and schizophrenia. The blood part includes the anemia, which is probably the nutritional and other hemoglobinopathies. The cancers include breast cancer, cervical cancer, lung cancer, oral or prostate cancer, colon and stomach cancers, and blood cancers like leukemia and lymphoma. The musculoskeletal system includes the arthritis. Next, please. The recommended components for prevention and management of NCDs in PLHIV include the health promotion or the primordial prevention, screening for early detection, the diagnosis, and the management including lifestyle changes and pharmacological therapy, the regular follow-up, which includes the monitoring, achievement of treatment goals, and monitoring adherence with side effects and drug-to-drug interactions being monitored. Next, please. The counseling messages related to health behavior includes the physical activity, which includes the active lifestyle with moderate levels of physical activity for at least 150 minutes per week. It might also include yoga and meditation. The weight control, which includes the weight management to maintain a healthy BMI. All individuals who are underweight or obesity should be encouraged to lose weight through a combination of a low-calorie diet and dynamic physical activity. The diet would include the balanced diet with whole grains, vegetables, fruits, and pulses. The diet shall be as per locally available items. We will have to restrict salt to less than 5 grams, that is 1 teaspoon per day, and limit use of sugar, fatty meals, dairy fat, and fried foods. Next, please. It would also include tobacco cessation. In tobacco cessation, multiple short-term and long-term benefits are there. We will have to encourage all non-smokers or tobacco chewers not to start smoking or tobacco chewing. Strongly advise all smokers and tobacco chewers to quit tobacco and support them in their efforts in doing so. Avoidance of alcohol, which includes the use of alcohol to be avoided by everyone as far as possible and as soon as possible. The counseling support for all people with alcohol use disorder or drinking in excess of moderation. Next, please. In relation to the adherence to the treatment, if the person is prescribed medication for the non-communicable diseases, we will have to explain the dose and how many times a day to take the medication that has been prescribed. We will have to explain how to take with ARVs along with additional medications. Explain the importance of adherence to medicines for NCDs along with the ART. We will have to explain the need to take medicines regularly as advised, and even if there are no symptoms visible. We will have to counsel on the possible side effects and advise to report back immediately if any side effect or any adverse reaction is experienced. Next. Next part, we will be covering with hypertension screening, diagnosis, and initial management for adult PLHIV. Next, please. For screening of hypertension in adult PLHIV, all PLHIV above the age of 18 years should undergo screening by healthcare providers through BP monitoring, which includes the registration into HIV care or ART initiation. It has to be done at every 6 months after ART initiation or separately as a screening examination as and when requested by the PLHIV or need felt by the healthcare provider based on the symptoms. Next, please. The diagnosis of hypertension in adult PLHIV would include a physician using a validated device and following a standardized BP measurement procedure. It should be based on at least 2 measurements taken on at least 2 visits, which are at least 1 to 4 weeks apart. The hypertension is diagnosed during the measurement in each case of hypertensive urgency, which is systolic BP more than 180 mm of mercury and or diastolic BP more than 110 mm of mercury with no evidence of acute target organ damage, and hypertensive emergencies which include systolic BP 180 millimeter of mercury and or diastolic BP more than 110 to 120 millimeter of mercury and is associated with cardiovascular or cerebral or renal damage or grade 3 or 4 retinopathy, where hypertension is diagnosed during the first measurement itself. And the hypertension should be diagnosed when BP is persistently above a systolic of 140 millimeter of mercury and or diastolic of 90 millimeter of mercury. Next, please. The diagnosis of hypertension in adult PLHIV with additional investigations if available. We can have fasting blood sugar for assessment of diabetes, urine analysis for proteinuria, which may be an early indication of diabetic nephropathy, and a marker for higher risk of cardiovascular morbidity and mortality. The desirable for PLHIV with systolic BP more than 160 millimeter of mercury and diastolic BP of more than 100 millimeter of mercury, which would include lipid profile for dyslipidemia, which is a cardiovascular risk factor, serum creatinine, sodium potassium for assessment of renal function, ECG evaluation for end organ damage such as left ventricular hypertrophy. Next, please. For management of hypertension in adult PLHIV, the target for BP control for patients below 80 years of age is systolic BP less than 140 millimeter of mercury and diastolic BP of less than 90 millimeter of mercury. And for patients 80 years or older is less than 150 millimeter of mercury systolic and less than 90 millimeter mercury of diastolic. All patients require lifelong lifestyle modifications, including dietary changes to heart-healthy diet, salt limited to 5 to 6 grams per day, which also includes low-fat diet, regular exercise, weight maintenance with target BMI of 18.5 to 22.9 kilogram per meter square, and smoking cessation wherever it is required. Next, please. For management of hypertension in adult PLHIV, continuation would be antihypertensive therapy for uncomplicated hypertension, and irrespective of whether HIV status is either mono or combination therapy with an angiotensin convertase enzyme, that is ACE inhibitors, for example, enalapril, the ARB or the angiotensin receptor blockers, for example, losartan, calcium channel blockers, amlodipine, thiazide diuretics, hydrochlorothiazide, or any beta blocker, for example, atenolol. Next, please. In continuation of management of hypertension in adults in PLHIV, grade 1 hypertension would include systolic BP more than 140 to 159 millimeter, with diastolic BP 90 to 99 millimeter of mercury, which may need lifestyle modifications to be tried for at least 3 months. And if the patient is not responding to lifestyle modifications alone, one drug pharmacotherapy with lifestyle modification can be implemented. If the grade 2 hypertension comes, which includes the systolic BP ranging from 160 to 179 millimeter of mercury, and diastolic BP from 100 to 109 millimeter of mercury, again the one drug monotherapy with lifestyle modification can be used. For grade 3 hypertension, in which systolic BP is more than or equal to 180 millimeter of mercury and diastolic BP is more than equal to 110 millimeter of mercury, we can use 2 drug monotherapy followed by lifestyle modifications. Next, please. For management of hypertension in adult patient, the continuation would include the dose of drugs can be increased or a new drug added at approximately 2 to 4 weeks of intervals if there are no visible changes. This frequency can be faster or slower depending on the clinical circumstances of the patient and the judgment of the treating physician. The patients with diabetes mellitus should be initiated on drug treatment when systolic BP is greater than 140 millimeter of mercury, and the target for control should be a systolic BP of 140 millimeter of mercury and a diastolic BP of less than 90 millimeter of mercury. The ACE inhibitors are preferred as initial therapy, and calcium channel blockers and diuretics may be used as an add-on therapy. Next, please. For drug interactions, ACE inhibitors and thiazide diuretics do not have any interaction with ARVs. There are potential interactions between calcium channel blockers and the beta blockers with ARVs. The drug levels of calcium channel blockers and beta blockers are increased in presence of PIs and decreased in the presence of NNRTIs. The dose adjustment of antihypertensive agent may be required in such cases. In drug levels of ARVs which are not affected by calcium channel blockers and beta blockers, there is no dose adjustment required for ARV. The caution should be exercised when administering beta blockers and PIs due to the risk of QT prolongation, and ECG monitoring is recommended along with this. Next, please. For screening, diagnosis, and initial management of hypertension, the care provision and referrals includes the screening, diagnosis, and treatment of uncomplicated hypertension, which can be provided by a trained medical officer. The grade 3 hypertension and a failure to achieve treatment goal following initiation and dose increase of 2 antihypertensives to maximum level shall be referred to the physician experienced in management of the hypertension. For immediate referral to appropriate facility, and the provider shall be done in cases of hypertensive urgencies and hypertensive emergencies. Next, please. Now comes the diabetes mellitus screening, diagnosis, and initial management for adult PLHIV. Next, please. For screening, diagnosis, and initial management, screening includes all PLHIV should undergo screening through random blood glucose test at registration into HIV care on ART initiation, at 1 to 2 months after ART initiation, and then at every 6 months. At change of regimen, that is at substitution or switch of any regimen, or separately as a screening examination as and when requested by the person. Next, please. While screening, one must look for symptoms of diabetes, which includes polyuria, polydipsia, weight loss despite polyphagia, tiredness, weakness, generalized pruritus, recurrent urogenital infections, delayed healing of wounds. The diagnostic criteria for diabetes includes the symptoms of diabetes plus casual or random plasma glucose more than equal to 200 milligram per dl, fasting plasma glucose more than equal to 126 milligram per dl, 2-hour post 75 gram glucose more than 200 milligram per dl as part of oral glucose tolerance test or the oral GTD. The glycated hemoglobin should not be more than 6.5%, more than equal to, and it has been reported that HbA1c levels underestimate glycemic levels by 10 to 15% in PLHIV. The diabetes diagnosed using any of these criteria should be confirmed with another test subsequently. Next, please. For monitoring of diabetes mellitus, blood glucose, fasting blood sugar, and 2-hour postprandial blood sugar at least once a month and more often if values are not in ideal target range. HbA1c at least every 6 to 12 months if available, and more often, that is every 3 months if values are not in the ideal target range. Clinical examination needs to be done during every visit, which could be minimum every 3 months. Screening for long-term complications like retinopathy, nephropathy, neuropathy, peripheral vascular disease or the PVD, and the coronary artery disease at least once in 6 months, more often if needed. Optimizing weight, waist circumference, blood pressure, and lipids. Routine examination of foot to be done during every visit, and education regarding foot care to be given to patients at each visits. We have to discourage tobacco use and excess use of alcohol in the patients. Next, please. For additional investigations, if available, we can go for lipid profile, serum creatinine, and urine analysis for proteinuria. Next, please. For management of patients with pre-diabetes, that is abnormal results but do not meet criteria above for diabetes, monitoring with fasting blood sugar or HbA1c if available every 6 months, and encouraging lifestyle modifications is recommended. For lifestyle modifications, as mentioned under health promotion, is recommended for all PLHIV with diabetes for lifelong. If target blood glucose is not achieved after lifestyle modifications within 3 to 6 months, or oral hypoglycemics shall be added, and give metformin for type 2 diabetes. Titrate metformin to target glucose values, that is fasting blood sugar 126 milligram per dl or HbA1c if available. Sulfonylurea may be given to patients who have contraindications to metformin or if metformin does not improve glycemic control. Patients with diabetes mellitus are at increased risk of developing TB. So that should be taken care of. Next, please. For drug interactions, metformin should be used with caution in PLHIV with renal insufficiency or liver disease or active infection including TB, and those with wasting or congestive cardiac failure due to the risk of lactic acidosis induced by metformin. A dose adjustment of metformin should be considered when co-administering with DTG with metformin in oral order to maintain glycemic control. It has been recommended to limit the totally daily dose of metformin to 1000 milligram when co-administered with DTG. For monitoring renal function and blood glucose, it is recommended that when metformin and DTG are co-administered, it should be done. NNRTIs and PIs may cause increase or decrease in level of sulfonylureas, which may require dose adjustment of sulfonylurea, and dose can be adjusted as needed based on blood glucose monitoring. Next, please. For care provision and referral, screening, diagnosis, and management through lifestyle modification can be provided by a trained medical officer. Initiation of oral hypoglycemic agents shall be done by a physician. Continuation of treatment can be provided by a trained medical officer in PLHIV with controlled diabetes. Management and follow-up by a physician are recommended in patients with uncontrolled hyperglycemia despite maximum dose of metformin and sulfonylurea, and patients with foot ulcers and patients with vision impairment. Next, please. In cardiovascular disease risk factors, screening, assessment, and initial management for adult PLHIV. We will continue with next, please. The risk factors include the hypertension, diabetes mellitus, dyslipidemia, that is high fasting total cholesterol, LDL or triglycerides, obesity, BMI more than 30 kilogram per meter square, and increased waist circumference. For men, it is 102 centimeter, and for women, it is 88 centimeter. Physical inactivity is another risk factor, which also includes tobacco use, excessive alcohol consumption, unhealthy diet and nutrition, family history of cardiovascular diseases. Next, please. For assessment, the assessment shall be done at time of registration in HIV care or ART initiation at 3 months and 6 months of ART, and shall be repeated every 6 months thereafter. We have to ask for a history of heart disease, stroke, diabetes, and hypertension, any angina, breathlessness, on exertion and lying flat, numbness or weakness of limbs, loss of weight, increased thirst, polyuria, puffiness of face, swelling of feet, passing of blood in urine, or any past or present treatment or any other medication that has been taken, current or past tobacco use and alcohol consumption, lifestyle, sedentary or active. We have to define premature heart disease or stroke in first degree relatives. We have to assess also for BMI and waist circumference. We have to measure blood pressure. Signs and symptoms of diabetes mellitus can be assessed. We have to examine for signs such as pitting edema, heart murmurs, basal crepitations in lungs, and tenderness in abdomen, and also look for lipid profile if available. Next, please. In management, all patients with history of angina, shortness of breath, numbness or weakness of limbs, loss of weight, increased thirst, polyuria, puffiness of face, swelling of feet, passing blood in urine, pitting edema, heart murmurs, basal crepitations in lung and tenderness in abdomen have to be referred. They have to follow with lifestyle modifications as mentioned under health promotion. The treatment for statins is recommended for all patients with established cardiovascular diseases and for patients with dyslipidemia. For managing dyslipidemia in PLHIV on ARV with known impact on lipid metabolism by PIs and efavirenz, single drug substitution to lipid-friendly drug is recommended if feasible. If lipid profile does not improve with lifestyle modification, lipid-lowering drugs like statin, that is atorvastatin, for example, may be added with starting dose of 10 milligram OD, ranging maximum to dose of 20 milligram if patient is on PI or ritonavir base, maximum dose of 80 milligram once daily if not on a PI/ritonavir base. Simvastatin and lovastatin are contraindicated in presence of PIs. Next, please. For mental health among PLHIV, next, please. PLHIV are prone to psychological ailments due to HIV, as per C, well as opinion and experiences regarding HIV in their surroundings. PLHIV may face multiple types of psychological issues like depression, anxiety, internalized stigma, etc. Any such issue can significantly hamper adherence and mental well-being. Depression is 2 or 3 times more prevalent in PLHIV than in general population. Next, please. For screening and for depression among PLHIV, all PLHIV should receive basic screening for depression before initiating ART and thereafter every 6 months using the following 2 questions. One is, during the past 2 weeks, have you often been bothered by feeling down, depressed, or hopeless? Second question is, during the past 2 weeks, have you often been bothered by little interest or pleasure in doing things? For thorough screening for depression using PHQ-9 screening tool and scoring pattern for PLHIV, answering yes, any other above questions. Next, please. This is the patient PHQ or the patient health questionnaire. You can just have a look of it with the grading with the numbers, and you can work accordingly for this. Next, please. For patient health questionnaire, scores and related conditions, we have total score ranging from 0 to 4, 5 to 9, 10 to 14, 15 to 19, or 20 to 27, with the conditions involving depression, unlikely, mild depression, moderate to severe depression, and severe depression, with the recommendations accordingly, which include repeat screening as per schedule, provide supportive counseling, and continue to monitor. If patient is on efavirenz, substitute with a different ARV after ruling out treatment failure. It also includes provide supportive counseling through trained counselors. If patient is on efavirenz base, substitute with a different ARV after ruling out treatment failure, and referral to psychiatrist for further management and antidepressant treatment as and when required according to the total scoring. Next, please. Key supportive counseling messages in PLHIV with depression include the psychosocial support, which includes explaining about the depression and ensure that it can be managed. Feeling of hopelessness, worthlessness, negative emotions are part of depression and will revert to proper counseling and treatment. Inform on course of counseling and treatment. Identify the supportive family members and involve them as appropriate or as and when required. Involve peers and community support groups for the psychosocial support. For self-management skill, we have to continue ART as prescribed is the key message. Also includes identifying activities that they use to find interesting and pleasurable. Encourage participation in these activities. Get a regular and sufficient sleep of approximately 7 to 8 hours, if possible. Also includes physical activities to be increased, and contact ART center or healthcare facility immediately if thoughts of self-harm arise or the patient feels that these are arising. For reducing the stress, we have to identify and try to reduce the stress points. We have to identify and discuss stress increasing points such as health issues, family and relationship problems, gender-based or partner violence, finances, stigma and discrimination. It also includes identifying and discussing the problem-solving techniques. Also suggests stress management such as meditation and relaxation techniques. Next, please. For medical management of depression, depression can be managed by a combination of medical and psychological interventions. Whenever needed, antidepressant should be prescribed by a psychiatrist. Antidepressant treatment is generally given for 6 to 9 months. Dosage should start with minimum recommended doses or increased as and when gradually. And it takes 2 to 4 weeks for maximum therapeutic benefits and improvement in symptoms to be achieved. Antidepressants should not be stopped abruptly. The dose should be tapered gradually. There are 2 main classes of antidepressants: tricyclic antidepressant, that is amitriptyline, and selective serotonin reuptake inhibitors, SSRI, that is the fluoxetine. Next, please. For drug-to-drug interactions, there are no drug interactions between NRTIs, NNRTIs, or integrase inhibitors and amitriptyline and fluoxetine. PIs increase the drug level of amitriptyline or fluoxetine, but no adjustment of dose of amitriptyline or fluoxetine is needed. Amitriptyline or fluoxetine do not affect the ARV drug levels. Amitriptyline and PIs should be administered with caution as both prolong the cardiac QT interval and ECG monitoring may be recommended as and when required. Next, please. For mental health in children and adolescents living with HIV, we have to assure that mental health disorders during childhood and adolescence are defined as delays or disruptions in developing age-appropriate thinking, behaviors, social skills, or regulation of emotions. The prevalence of mental health conditions in children and adolescents varies between 6% and 12%. The prevalence of 7.3% in children and adolescents, it varies from age 13 to 17 years. Overall, 8 to 13% of children are estimated to need mental health services. Next, please. The warning signs indicating presence of mental health condition in children and adolescents includes persistent sadness for more than two or more weeks, withdrawing from or avoiding social interactions, hurting oneself or talking about hurting oneself, talking about death or suicide, outburst or extreme irritability, out of control behavior that can be harmful, drastic changes in mood, behavior, or personality, changes in eating habits, loss of weight, difficulty in sleeping, frequent headaches or stomach aches, difficulty in concentrating, changes in academic performance, and avoiding or missing school. Next, please. The common cancers among PLHIV include the prevention part includes the screen for tobacco use, counsel on adverse effects of tobacco and encourage to quit tobacco use, promote healthy dietary practices and physical activity. The general guidance for PLHIV on treatment for cancer would include PLHIV receiving radiotherapy or surgical intervention should continue taking ART. They should not stop it. In PLHIV receiving chemotherapy, the treating physician and oncologist shall discuss and prepare individualized plan considering the potential interactions and toxicities profile. Next, please. For early detection of cancers, create awareness about the early warning signs of cancer like the following: change in bowel or bladder habits, wound that does not heal, unusual bleeding or discharge, thickening or lump in the breast or elsewhere, indigestion or difficulty in swallowing, obvious change in a wart or a mole, nagging cough or hoarseness of voice. Educate the patient on self-examination and reporting for unusual signs and symptoms. Examine the patient for warning signs and routine examination of oral cavity, breast, and the cervix. Refer any person with a suspicious lesion for accurate diagnosis and appropriate treatment. Next, please. Cervical cancer screening in PLHIV include the screening frequency at ART initiation. We have to repeat screening within 3 years if the initial test is negative. Women who have been treated should receive follow-up screening at 1 year, any other time if related signs and symptoms are reported. For methods of screening, visual inspection with acetic acid, BIA, 3% to 5% acetic acid is generally applied to the mouth of the cervix, that is the ectocervix area, and the presence of an acito-white lesion is noted. For observations, normal squamous epithelium of vagina appears pink. The columnar epithelium of uterus appears red. In conditions like inflammation, benign and malignant growth, the epithelium contains a lot of cellular proteins because of increased nuclear activity, thereby giving a dramatic dense white patch, that is VIA positive. For referrals, if screen positive, refer to a gynecologist or a lady medical officer wherever available, or NCD clinic at CHC or district hospital for confirmation and further management. Next, please. For PLHIV group, all women living with HIV above 30 years of age, the risk factors include reproductive and hormonal factors, which are older age at first pregnancy, early menarche, that is before the age of 12 years, late menopause, that is after the age of 55 years, never had children, women who take menopausal hormonal therapy, which includes estrogen and progesterone for 5 years or more after menopause. The risk factors also include the family history with risk of breast cancer increase in women with a first degree relative with breast cancer. Other factors include being obese after menopause, physical inactivity, and alcohol intake. Next, please. For breast awareness in all women living with HIV above 30 years of age, the women should be counseled on breast awareness. The first person to detect any lump in the breast is the woman herself, which is by teaching the woman, to be aware of any of the following signs at the earliest possible, with change in size, nipple that is pulled in or changed in position or shape, rash on or around the nipple, discharge from one or both nipples, puckering or dimpling of skin, lump or thickening in the breast, constant pain in the breast or armpit. Next, please. The screening also includes all women living with HIV of age more than 30 years should be screened using clinical breast examination. And the clinical breast examination is to be performed by a trained physician or a nurse. The screening shall be done at ART initiation and can be repeated within 3 years if the initial test is negative, and any other time if related signs and symptoms are reported. For method, the clinical breast examination should be both breasts are visually inspected and palpated in different positions from all sides. Next, please. For observations through clinical breast examination, the following are noted: the inspection, which includes any change in symmetry in breast shape and size, skin changes, dimpling, retraction, or ulceration, the level of both nipples, retraction of nipples, nipple or nipples, and inverted nipple. In palpation, any discharge from the nipple or nipples, color of the discharge, swelling, lumps, consistency of lumps, swelling in the armpit, that is the axillary area, above the collarbone, that is the supraclavicular area, and the root of the neck, that is the infraclavicular area. The referrals include the clinical breast examination. If it is negative, no signs or symptoms noticed, follow up as per routine screening schedule. If it is positive, the positive findings are noted during the clinical breast examination and the referral to surgeon for further evaluation, followed by ultrasound and biopsy, etc., with diagnosis and management should be done. Next, please. For oral cancer in screening in PLHIV, the risk factor includes the tobacco chewing, which is the single most important risk factor for oral cancer. Other factors include alcohol use, betel nut chewing, or chronic trauma to oral mucosa by a sharp tooth or ill-fitting dentures. For health promotion, we can advise them for adequate emphasis made for cessation of tobacco use. For screening frequency, all PLHIV more than 30 years of age should be screened using oral visual examination, and screening shall be done at ART initiation. Repeat screening within 3 years if the initial test is negative, and any other time if related signs and symptoms are reported. The method of screening would be oral visual examination, which includes the observations, which are any abnormality shall be noted down. Specially mentioned precancerous lesions, if any. The precancerous lesions or conditions are local or generalized disturbances that predispose to malignancy in a particular area, which includes leukoplakia, erythroplakia, palatal changes associated with reverse smoking or BD smoking, or the submucosal fibrosis. And the referrals, if any abnormality is noted during visual examination of the oral cavity, PLHIV need to be referred to surgeon or an ENT specialist for further evaluation, diagnosis, and management. Next, please.
Thank you so much, sir, for facilitating this session. Any questions from the participants? Please feel free to unmute your mic. Any questions regarding NCDs or mental health? Sir, I don't think there are any questions. Can I quickly run the feedback poll, sir?
Yes, please.
Thank you, sir. The feedback poll is now visible on your screen. There are 4 questions in all. Requesting all the participants to please attempt the feedback poll. Requesting all the participants to please take the feedback poll. Only 12 participants have attempted the feedback poll, requesting all others to answer the questions. The feedback poll is visible on your screen. Once again, thank you so much, sir, for facilitating this session. Thank you to all the participants for patient listening. So can we conclude the session now?
Yes, please.
Thank you, sir.
Thank you.